क्या करता है? Lactic plus has resins. Broth है अंदर, the liquid is a broth. And जब उसको घुमाओगे ना, you will get some solid floating materials. है ना? थोड़ा थोड़ा अंदर.
Yes.
Okay.
Crystal.
हाँ, जो crystallize होते हैं, just shake and see. Those things are resins. Resin क्या करता है? If your blood has antibiotics already, then it will bind to the antibiotics and it will precipitate it. Okay, and precipitate करने के बाद your bacteria yield will increase. And the reason why you have only these bottles here is because most of the patients coming to tertiary care will already be pre-treated with antibiotics elsewhere, which is why it makes sense to keep this set rather than the normal set. Normal set is a normal Bactec, which is a blue top and a yellow top. Okay, blue top, yellow top is a Bactec set. Grey tops and purple tops are Bactec plus. उसमें से भी एक anaerobic bottle है, एक aerobic bottle है. Okay. Why does this make a difference? Why should you send both? मैं सिर्फ aerobic भेज सकता हूँ. Why to waste 10 ml of blood? Anaerobic sepsis होता है नहीं होता? What is it? It is common. It doesn't get picked up on cultures. Anaerobes are very poor culture growers. Okay, so sending an anaerobic bottle makes sense because many times GI infections, urinary infections, you will have anaerobes, but you will never grow. Okay. Second thing is even your gram-positive, your GNBs and gram-positive organisms are facultative anaerobes, meaning in anaerobic condition they will actually grow. And many a times you've seen the blood cultures flag earlier in the anaerobic bottle than the aerobic bottle. So many a time when you ask for your culture reports in the morning, you see anaerobic is flagged and aerobic is not flagged. You will have seen this pattern. So it helps in earlier diagnosis many times. Okay, which is why it's important to send even the anaerobic bottle. Okay, not just the aerobic bottle. For anaerobic culture also and for aerobes which are facultative anaerobes. So jaldi pick up hoga on the anaerobic bottle. Okay. Abhi, now you've told your sister, chalo bahar se patient ko antibiotic mil chuka hai, patient has come in sepsis. You've told them to take a sample in the blood culture bottle. Now, how does the sister proceed, or how do you tell them to proceed? Will you collect a sample in this? So you took a 20 cc syringe, prick liya, 20 cc blood nikala. After that, what do you do? How?
Without opening.
Without opening, how do you put? इसमें cap है ना?
नहीं cap निकालने के बाद directly कर सकते हैं.
हाँ, so that is the wrong thing. Why? Because this has been lying in your ward for days, months, you don't know. Now it is colonized with bacteria. So once you open the top, clean the top with a spirit. Okay, this is one common mistake that nurses, staff who have colors of cultures, they don't clean it, and then you get contamination. Contamination happens at two places. Not cleaned here properly, not cleaned on the top properly. Okay, very important. Clean the side properly, clean the top properly. Okay, then your contamination rates go low. There is no other source of contamination. अंदर sterile है, अंदर जाके कहीं पे system में कहीं पे भी contamination नहीं. So these two places you take care, contamination rates are very good. Okay, because one contaminated bottle is 3,000 rupees longer drain. There is no point in sending the sample. So avoid contamination. Now, how much sample to collect in one set and how much to put in each bottle? If you check the bottle, it's written there.
8 to 10 ml.
So ideally, 20 ml per sample, 10 ml in aerobic and anaerobic bottle each. Okay, important. Suppose blood sample come, nikla patient shock mein, so you will probably have collapsed veins and the blood will not come properly. In which case, what will you do? Okay, if you're immediately putting a central line, put in a line, take in a sample, label it as peripheral sample. You don't want it to be mislabeled as line-related infection and फालतू में बाप में line निकाल. Okay, because that will be as good as a peripheral sample. Otherwise, suppose मुझे 6 ml blood मिला, 10 ml मिला और फिर vein collapse हो गया. Put that into a single bottle. चलिए. Most commonly, 99% of the times it will be an aerobic organism. Okay, so very commonly, at least guidelines tell you that अगर कम sample मिलता है तो you put it in the aerobic bottle and send it off. Okay. See, I told you many of them will grow in the anaerobic also. Not all of them will grow in the anaerobic. So putting in the anaerobic will actually be a mistake. Put it in the aerobic bottle and send it off.
Single bottle.
Single bottle. अगर कम sample मिलता है तो. Okay, you get anything about 10 ml, you can divide and put, or preferably put as much sample in single bottle and send. Okay, send it as soon as possible. Transit time should be minimum. जैसे sample collect किया, तुरंत तुम्हारे lab में पहुंचने से should go into the machine. but any delay will decrease the culture yield eventually. Okay, and then it goes into the system where it gets inoculated or incubated at body temperature. After that, what happens? Next step. Randomly रात को 10 बजे कॉल आता है GNB flag में. What is this about?
Something has grown.
Something has
So it will grow inside. How does a technician go at 10:05 p.m. that there is a growth in the machine?
Automatic will
मशीन को कैसे मालूम पड़ता है कि अंदर बैक्टीरिया है?
changes in
Color.
pressure, carbon dioxide.
So machine has a series of, I don't know if it's infrared or waves, and there is a difference in the carbon dioxide concentration which gets picked up inside the system. Okay, so machine में slots डालते हैं ना, all 360 degrees से ना, there are sensors who are sensing the carbon dioxide inside. तो कोई भी bottle में अगर उनको लगता है कि carbon dioxide is high, that particular sample gets beeped. And once it's beeped, okay, 24 hours the technician is there in the lab, they will take the bottle out. What will they do after that? How do they know it's a GMB? What do they know it's a? They will take blood from it. 2 cc syringe लेंगे, वापस उसमें से blood लेंगे, slide पे पहले ये करेंगे, लगाएंगे, gram stain करेंगे, तुरंत 6-10 minutes for a gram stain, okay, and then they will see. And what will they see? Stain के ऊपर what is gram positive color and what is gram negative color, what is the focus and what is the bacillus.
Pink.
Okay, what important is हमारे?
Positive is pink, है ना? Gram positive is pink. Negative is blue.
Cell wall.
Focus is circular.
So dark blue is gram positive. The pink is
negative.
negative. Also depends on your staining. If you're not stained it properly, blue can become pink also. Okay, staining technique has to be very, very important. Bacillus is rods. Okay, and foci are
Grapes.
circular. तो अभी उनको मालूम पड़ा कि patient sample has a gram positive focus, has been informed from the lab. What is the next thing that you ask for? Sensitivity के पहले organism कैसे मालूम पड़ेगा gram stain?
Culture serial culture.
तो उस gram stain करने के बाद they will inoculate, they will subculture it onto a
Culture
on
model.
a blood agar or a regular agar plate, okay, on a normal agar or a blood agar plate. फिर वो जाएगा तीसरे दिन पे वापस ग्रोथ आने के बाद what will happen?
Organism
Pick up all.
कैसे मालूम पड़ेगा?
वो उस पे ग्रो करेगा स्पेसिफिक विद ऑल द broth.
Blood agar.
The disc are different for gram positive.
This is for antibiotic sensitivity. Organism
Agar plate.
अगर प्लेट पे तो ग्रोथ आएगा, स्लाइमी आएगा, व्हाइट कलर का पूरा ये आएगा. हाउ डू यू से दैट ये दिस ग्रोथ इज स्टाफ ऑरियस, दिस ग्रोथ इज एंटरोकोकस, दिस ग्रोथ इज स्ट्रेप्टोकोकस, दिस ग्रोथ इज ई कोलाई.
Colony pattern.
Colony pattern. You can make an estimate out of it, but तुम्हारे को when they give you a report, it is with almost 99.99% accuracy. Colony pattern थोड़ी देख के करते हैं.
Morphology of colony.
Not at all.
वो कैरेक्टर लैक्टोज
You are talking about 10, 15, 20 years ago when they used to do this. Now you have automated system for everything. You read your culture report properly. क्या लिखा? Identified by what? They write the method and give it.
Dilution.
There's a machine called as Vitec 2 in your IC, in your microbiology lab. Vitec 2 is a machine. Okay, या फिर दूसरा मशीन आता है Milditop. Okay, Milditop हर जगह नहीं होता. Milditop बड़ा मशीन है, which is more organisms and more accurate. Okay. Vitec 2 is a machine. It's important by for two things. एक तो identification भी करता है और दूसरा sensitivity भी देता है. आजकल तुम्हारे लैब में बैठ के वो लोग ये करके डस्ट नहीं खेलते हैं. It's all old concepts now. Okay, now they will put it on a. There is a cartridge. Cartridge में वो तुम्हारा sample थोड़ा inoculate करते हैं. Machine में वो antibiotics के साथ it will inoculate. This thing get mixed. That sensitivity gets automatically detected, and it all comes as a report now. And no one does all those discs and all. There are indications where it is done, but 90% of your isolates will go into a machine. They get identified, and the next day you will get a sensitivity because of a Vitec 2 system in your thing. It's all automated. Okay, automated के भी limitations हैं. For example, many a time you will find colistin MIC बहुत high है, colistin resistant आ गया ये वो, all that. It is very inferior for specialized drugs like colistin, where you have to use other methods to do it. But at least तुम्हारा meropenem, diptazo, Cefalobacter, mamic acid, ये सब के लिए this is a very standard and it's automated. It's not done distribution anymore. You can confirm it when you have any discrepancies. तुम्हारा रिपोर्ट दिखा रहा है कि meropenem resistant है और peptide sensitive है for an E. coli, it's impossible. Where you will reconfirm it by distribution and then you will do it. Okay? So all those are old time. So organism identification हो गया, sensitivity हो गया. So this is all later. Now you are in the ICU at night. You have a patient of sepsis. तुम्हारा gram negative flag हो गया, तुम्हारा gram positive flag हो गया. The gram positive में what are you worried of and what extra information will lead to your presumptive diagnosis? Staph. Okay, you're worried about staph. Okay. So what will you ask the lab technician even at 12 midnight जैसे GPC आया है? तो what will lead me to think ये staph है या staph नहीं है? Staph bacteremia very important. It's an emergency. You will ask for morphology on the slide. Well, you ask whether it is in chains or clusters. Okay. Important. ये basic है. ये 24-hour facility available होता है. Technician बताते भी हैं. तुम पूछते नहीं हो करके वो नहीं बताते. Okay. They will say उनका काम उतना है GPC GNB बोल के finish it. You ask them. Is there in clusters or is there in chains? Clusters is staph. Chains is strep or enterococcus. Okay. Strep or enterococcus. Short chains is enterococcus. Long chains is streptococcus. But chains बोल दिया तो पूरा diagnosis changes and clusters बोल दिया तो diagnosis changes. Again, it could be contamination. Even coagulous negative staph contaminants also will be GPC in clusters. Okay.
Could we say that pneumonia, pneumococcus and pathogens we could differentiate with the number of length of the chains?
Not so much.
Not so much.
Upfront, it will need a very skilled microbiologist.
Very skilled, but some skilled microbiologists may able to tell us that this is
so it pneumococcus, it rarely comes in the blood, but if it does, it looks like do you have a marker? It's a diplococcus. Basically, it will be gram positive. If we have okay. If I have images, I'll show you. It looks like this. There are CSF gram stains where you see pneumococci. There's a diplococcus with a capsule. So you'll see mostly in tracheal secretions and in CNS. But blood may hardly you will ever find. Very rare. Okay. So gram-negative diplococcus is what is there in pneumococcus. Okay. I'll share. I have this picture with me. एक बार तुम्हारा GPC in clusters हो गया and GPC in chains हो गया या management changes. We'll discuss individual pathogens later on. They're separate topics altogether. Now you got an emergency management gram positive हो गया. You went for something like teicoplanin, mincomycin, that to cover everything. We'll discuss individual this later. Gram negative आ गया. So you will, if the patient is sick, you will go for a carbapenem or above. Patient is not, you will wait for ID and sensitivity. Okay. Now we are evolving to getting diagnosis earlier and earlier. Okay. अभी कौन बैठेगा GPC flag हुआ है, GNB flag हुआ है, day 2 पे you'll get an ID, day 3 पे you'll get sensitivity. Imagine in a septic shock patient, you're waiting 3 days to get a diagnosis of the blood culture. And today everything is available at your fingertips 10 minutes में, 15 minutes में. So is there anything we can do to optimize this process to get this earlier? BCID, now BCID 2 panel. Basically, everything is biofires. You send a swab, in 1 hour you have a report for upper respiratory, for a stool in 2 hours you have for a lower GI. For CSF you have in 1 hour. So blood के लिए भी है. Unfortunately, something which is not available here as of now, but blood के लिए भी एक panel है called as BCID2. We have BCID2 now. BCID1 has been discontinued almost 5 years ago. Okay, BCID2 gives you almost 43 targets, जिसमें 34-35 organisms हैं and there are 8-9 resistance mechanisms. Okay, we'll discuss BCID2 in detail sometime later once you discuss gram-negative resistances. नहीं तो there's no meaning to it. But you should know there's a panel available to get an earlier diagnosis in a sepsis. Once you have blood culture positivity, that blood is sent and basically जैसे ही biofire करते हैं, तुम्हारा upper respiratory swab भेजा, वो BTN से वो liquid उन्होंने लिया, they put it in a small container and put it into a biofire apparatus, and within 45 minutes the reports come. Same thing for BCID also. Okay, BCID2. We've done extensive studies on it before. I'll present even that findings sometime to discuss it later on the BCID2 pros and cons and limitations, and how molecular is a confusing thing even today. So you should know that it exists, and if needed, it should be done. A neutropenic patient, sepsis, you will not wait 3 days for an organism. You want it immediately. So ऐसे cases में you will want to do a BCID panel and get your diagnosis sorted. And a stable patient who's vitally holding, otherwise okay bacteria, you will wait. You will not spend 20,000 on a test for a stable patient. So you have to know where to do it or not. Now, send a blood culture. We'll come to your report comes. Okay. Now the report comes as I give you 5-6 samples. Now, one report is an Acinetobacter lowfi, LWOFII. Second thing is a Klebsiella oxytoca. Third is an E. coli. Fourth is a Staph hemolyticus. Fifth is an Enterococcus gallinarum, and sixth is a Strep bovis. Now you have 6 reports. 3 ग्राम नेगेटिव है, 3 ग्राम पॉजिटिव है. इनमें से what will get your antennas up, what will get कि ठीक है ये contaminant हो सकता है. See basically the seriousness of a culture report. Now I'll start with इनमें से कौन सा contaminant हो सकता है. So 7th is a Candida albicans. Out of these, what can be a contaminant? What is not a contaminant?
Candida can be a contaminant, no?
Sorry. Staph hemolyticus is a coagulous negative staph. Most likely will be a contaminant. Most likely. Always never disregard. Why? I will always look at the second bottle. And अगर second bottle में positive है, then कुछ तो गड़बड़ है. This is a true bacteria. Understand this. Okay, the second bottle improved because it comes from different prick. What are the chances that you will contaminate both pricks with the same organism?
Exactly what
Unlikely.
we can talk about the patient on bed number 4, right? On bed number 4, there were 4 blood cultures that were sent. Only one bottle grew one of the organisms, and then we were discussing this has to be a contaminant. So what doctor is trying to intend to say is that when you have 2 organisms growing, then from both the sides it is growing the same organism, provided it is taken from 2 different sites and not from the same syringe and put at 10 ml. Then you have to clearly think that this is not a contaminant. This is a pathogenic organism. That is the etiology rather.
I'll share a case from 3-4 years ago. Patient was a CKD on a tunnel cath. I was undergoing dialysis, and she was having fevers. Okay, sent off a line blood culture, and usually it's very common for a tunnel cath culture to be contaminated because 100 people handle the line in different dialysis centers, and उसमें से ये got a staph, if I'm not wrong, hemolyticus only. Okay. After that, disregarded contaminant है, usual जो चल रहा था, continued. Sent off, but our antenna went up that we should investigate this. Sent off a peripheral culture, 2 peripheral cultures, both grow staph hemolyticus. Okay, then we did an echo, tunnel catheter tip pe there was a vegetation which was pedunculated and going on. Okay, so a contaminant in the right setting, if you have a line, tunnel cath and all, it can become a true pathogen when it's not handled properly. Okay. What are the other contaminants that इनमें से ये 6-7 चीज में is a Candida contaminant?
Number of colonies.
In a blood, will you look at number of colonies? Urine, respiratory secretions, I will understand. Respiratory secretion में तो मैं गिनूंगा भी नहीं. Urine में चलो number of colonies will be significant. Blood में is usually not a contaminant. Okay. Candida is not something which is part of your skin flora. Usually part of your oral urogenetic colon GI. Okay, not on the surface staph. What else is your surface colonizers which can become contaminants?
Epidermidis.
Staph epidermidis. Basically all non-aureus staph, coagulous negative staph. और क्या है? Diphtheroids आते हैं. Okay, cornea and diphtheroids, diphtheria-like organisms, micrococcus. Now you get these organisms many a times, okay, on your cultures. These are all contaminants. Candida is not a contaminant. Okay, of all the other cultures that I told you, Acinetto, Pseudo, in all its forms, Enterococcus, Staph aureus, Strep bovis, all of this will not be contaminated. They are true pathogens. अभी इनमें से two bugs will raise your antenna as to investigate further, मतलब very much further.
Acinetobacter.
Cleve oxytocin is not.
Acid.
But GNB came from the urine of the GI.
Acinetobacter.
Acinetobacter is a very common cause of nosocomial bacteria. What will get your antennas up? When you think of a serious infection like a endocarditis, important.
Endrop.
Next thing is disregard contaminants. Second thing is know when to suspect endocarditis and aggressively investigate for it.
Enterobacterias.
Remember Leonthor enterococcus endocarditis uncle recurrent since 1 year. Sent off 3 cultures, came positive in I think 2 out of 3 cultures, and he had a vegetation on the wall. Okay, what was the organism which came?
Enterop.
Which enterococcus? There are 6 types of enterococcus. Enterococcus fecalis, important. Enterococcus fecalis is a gut bug which, when translocates, latches onto the heart walls, causes endocarditis. Versus Faecium is usually a nosocomial pathogen, extremely drug resistant, usually does not cause endocarditis. So, Enterococcus faecium, raise your antenna for endocarditis. 4 organisms which should raise your antenna for endocarditis and evaluation. Enterococcus fecalis एक बता दिया. Second, Staph aureus. Staph aureus is very important. Okay, Staph aureus always rule out. Okay, and there is no over investigating this. Push for the TE, push for your cardiac bite. This that. If you are having Staph bacteremia, you have to rule out endocarditis. Third is Streptococcus. Which species of Streptococcus? Viridans group Streptococcus, Streptococcus group, Streptococcus caracti, etc. Okay, have to be investigated for endocarditis. Fourth is Candida. Okay, these are all endocarditis causing organisms which have, if you read Staph in detail, it has something called as MSC, RAMMs. Basically, it's very sticky, in short. So it will go and stick around wherever it finds place, and wall is another place it loves. So wall में थोड़ा भी उसको जगह मिल गया, it will stick, cause endocarditis and vegetation. Okay. So you will pursue, even if you have a Staph bacteremia, I will check ऊपर से नीचे तक IMA, embolic phenomenon, this, that, blah, 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 and go for even a transvascular echo if needed, okay, or a cardiac PET. Now, endocarditis is a separate topic, do that later. Now I'm having a blood culture positive with Staph, I started proper anti-Staph therapy. What I'm coming to is, do you send repeat cultures? In which cases do you send repeat cultures to document clearance? In which cases you do not send? Do you usually send repeat cultures to document clearance of bacteria? There are cases where you have to. Which are those cases?
Fungal cultures.
If Candida, yes. All of the endocarditis causing organisms, mainly gram positives, always check repeat cultures to document clearance. Okay, because duration of therapy in gram positive infection, gram negative infection is very different. Gram negative mein, since starting treatment, it is 10 to 14 days in uncomplicated GMB infections. However, gram positives के लिए duration of treatment is 2 weeks from last negative blood culture, first negative blood culture. The difference is this, because gram positive organisms are very difficult to eradicate, especially Staph. Okay. And endocarditis method 100% उनको daily blood culture भेजना है, ideally. In resource limited settings like ours, we usually send 48 to 72 hours. Okay. Ideally every day. In endocarditis, send blood cultures every day. In Staph, enterococcus and all these gram-positive organisms, ideally send every 48 to 72 hours to document clearance. Okay, 48 hours is ideal. Okay. Again, something that we did for the endocarditis patient. Send a repeat culture after 48 hours and that is negative. Okay. Do you send it for GNBs, E. coli, Klebsiellas in the blood, Acinitos in the blood, pseudo? Usually you do not. However, if fever is persistent, you would. Okay, if patient is not clinically improving, then you would. But if it's improving, GNBs, then you should not ideally send blood cultures because they're not organisms who are difficult to eradicate or directed treatment, unless you're missing out something. If your blood culture is coming positive again and again, last topic today. अभी ऊपर enterococcus uncle था, endocarditis था, we signed this thing, started ampicillin, 3 days later, again blood culture is positive, again we continue same therapy, 2 days later, again blood culture is positive. Now what is the meaning of persistently positive blood cultures?
Antibiotics are not working. Resistance.
Why are they not working?
Resistance.
Enterococcus fecalis में ampicillin resistance extremely rare है, कभी नहीं होता.
Inadequate dose.
Dosing, check dosing, very important. Check dosing is going all right. Next. होता है। अभी बैक्टीरिया में तो है all this understood कि ये enterococcus ही है। Why is it coming positive or positive if you're giving good 24 grams of ampicillin a day?
वो लोड ज्यादा नहीं।
Exactly. What is the thing about load ज़्यादा रहेगा? Endocarditis. Endocarditis is a huge inoculum load. Which is why we offer them surgery. This is why you take the load off. Endocarditis हमारा and दूसरा problem है penetrating into endocarditis is very difficult. Your bacteria is in the center of the vegetation. ये पूरा fibrin है उसके आजू बाजू. And this is your wall. So your normal dose, if you see ampicillin dose for enterobacterium without endocarditis, is 2 grams 6 hourly. Becomes 4 hourly when you have endocarditis because it's very difficult to penetrate a vegetation. Plus अंदर इतना सारा organisms पड़ा हुआ है. So when you have an uncontrolled source, important. Suppose endocarditis नहीं है, तुम्हारे पास एक renal abscess है. Same thing. Unless you source control, you are not going to get a negative bacteria, which is why you have to aggressively chase the diagnosis where it's coming from. Important. Antibiotic dosing, source endocarditis. Okay. Surgery again we will discuss endocarditis later. And any other even contaminants discuss. Okay.
So what Dr. Shetty has explained is very, very important for all of us. Okay, we understood what blood culture is very nicely explained, how blood culture, is so few things that take away what he said is it's very essential that we set the blood cultures in time. That is most important. Whatever SN, whatever lytic agent you have inside the system will do a job but not do a good job. That's why it's important to set these cultures so that these people understand. Okay, so say for example, I got to I think that the line is a source of infection. So they were asking me about why we are not removing the line and sending it for blood cultures and culturing the tip. Someone was asking me this some days ago.
The tip culture is now out of fashion. I mean out of guidelines also. Okay, tip culture is not usually representative. I won't say not usually, but not accurately representative of the line calling because the biofilm is lying inside the catheter. Okay, तुम्हारा जो catheter है, so this is the catheter, now this is your tip, and this is where your blood is going from. You are culturing this portion when the bacteria is lying here inside. You have to understand the concept of a biofilm. Okay, this is a biofilm which is lying inside. However, when you are manipulating a line, when you are removing the line and sending a culture tip, you can actually contaminate this with skin surface organisms. And more often than not, your line dressing will be soiled, there will be something going on. You will catch a wrong organism and will get misled and you will unnecessarily treat it. Okay. However, I will put a caveat to this that if your cultures are not positive anyhow and you're still suspecting line, you may still send. I'm putting it as a may. And I do send it sometimes. But routinely we don't. Okay, because of this particular reason. Biofilm happens elsewhere and the sample is something else. If in the future we have a mechanism where we can actually take the biofilm off a culture, then that would be perfect. Because that is the proof of the pudding.
So we do understand that when we are doing central line related blood and want to find CLABSI or CRPSI, we know that if you have differential time to positivity, you talk about it being CLABSI. That means it grows after 2 hours. Central line grows first and the peripheral line grows 2 hours later. That is CLAB. But you can have 3-4 scenarios in this where one is positive and the other is negative. So what he specifically said was if the peripheral line grows first and then the central line grows, it's probably going to be it's a bacteremia and probably line is not the source of infection here. But what happens if the central line grows and the periphery doesn't grow? Then what do? You understanding? The scenario one is nothing is growing, so there is no culture. There is no bacteremia. You have peripheral and central growing, and peripheral is growing first and central is growing later. Which basically means it's bacteremia and line is not the source of infection. It is not a CRBSI. The difference between CRBS and CLABSI is what? A central line associated bloodstream infection is an epidemiological tool, whereas CRBSI is when you have the symptoms. When you have the symptoms along with it is catheter related bloodstream infections. So that means CLABSI will overestimate the amount of infections. Got the point? Or shall I explain again? CLABSI means what?
These are CRBSIs inside a CLABSI.
Exactly.
Okay, if you have a bacteremia in a patient with a line, any bacteremia, becomes a CLABSI, does not make it a CRBSI. However, if you have a DTP of 2 hours positive between a line and a central line, it becomes CRBSI. Your infection control nurse who goes on the ICU, she screens the CLABSIs, and then she will take the opinion of the physician, intensivist, microbiologist to determine what is a CRBSI. And that becomes her true infection control rate or basically data.
Clear, no? So, but what happens for the audience is, what happens if the central line grows and the peripheral doesn't grow, and when do you consider that as to be important?
So, when a central line grows, basically this has grown. Okay, whatever is inside, because you're collecting blood from the line. So you know for sure there's a biofilm. That is established. If the central line blood is growing something, you know for sure there's a biofilm. Okay, if your sample technique and all is proper and your line handling method and all is very good, excluding contamination. Now in a peripheral blood, there are so many caveats, in this. What if your peripheral blood has not been sampled properly? 5 ml beta culture negative iron. So you are actually missing out on a CRBSI. So there's both things possible. That it is a CLABSI with another source of fever, or it is a CRBSI where your sample has not been sent. So in these cases, what I do a thorough source evaluation. ऊपर से नीचे तक we see urine में कितना पस है. Are there any other problem, any other cellulitis, bed sore, gastroenteritis, VAP, and all? We rule out everything else, and then you go for the line. And thinking that the peripheral blood was inadequately collected. This is what we practically do.
So, but 2 things over that you'll never forget is what he said is, if there's Candida. If there's Candida, don't think twice. You just treat it. I mean, you just don't think twice. You got the point. If there's Candida, fungus entirely, irrespective of the CLABSI, of say, just treat it as CLABSI, get off the lines, let it fly off. Okay. Now, there was one doubt in my mind that it's just my mind. Okay. That you might think that, if there's a central line, there's always going to be a biofilm. There is always going to be a biofilm. The moment you put the line, within hours, the biofilm starts getting formed. But that doesn't mean that every time you'll get positive. So you get always a blood culture that's positive. You got the point what I'm saying? It doesn't mean that every time you'll get a blood culture that is coming from the central line to be positive. In fact, venipunctures have got a higher contaminant rate compared to arterial line compared to central lines. You got the point. The contaminant rate is much higher that you may not grow anything from the blood. So I have this question also in my mind that when you have no other place from where you can collect blood, and you have 2 hubs and you want to figure out whether there is still a CLABSI, would it make any sense for me to send one hub and the other hub and find the colony forming units quantitatively and decide whether it is a central related plastic infection? I mean, this is a question asked in the exam also, in our IDCCM exams.
In dialysis catheters, we do.
Yeah.
We have central line red hub and central line blue hub. Alag se they send usually 2 from the double lumen catheter, the triple lumen, and 3 plus peripheral, right? Depending on how the catheter is.
And a step up of the organisms might indicate. Step up of the organisms.
There are a couple of organisms which are sticky. I told you. Beware of sticky organisms. उसमें से Candida एक है, Staph aureus. Because Staph aureus coming from the line and nothing in the peripheral, I would still consider removing it. If I'm getting Candida from the line, I would consider removing it. Okay. If I get sticky organisms, I have to take it out. Okay. If I have no other source, I will change it to give benefit of doubt to the patient. Unless that is so precious and not getting anything else, get 5,000, 10,000, then it's a different story. Okay. Colony count, again, there are no established guidelines on the blood. They say every blood culture growth is significant. So usually you will see colony count in tracheal secretion, you'll see in urinary tract samples, but anywhere else they'll not usually give you a colony count. Because any growth is significant. 100 colonies be higher, Staph aureus is significant versus 10,000 colonies or something else. So somehow quantification of blood culture is not favored usually.
And to put it very clearly, even 10 colony forming units or 10 raised to 3 colony forming units can be picked up in blood culture. Even 10. Okay, less than 10 it may not pick up, less than 10 a PCR picks up. But 10 is something that the blood culture will have the denomination as. Now there's one very important question I want to answer, and this is probably the final question, I'll not take too much time, is there are, unfortunately this blood culture has become like water. Everybody and anybody is sending blood cultures, and there has to be certain times when you will not send the blood culture. Well, that also people should understand that any patient that comes in, which patients in the intensive care, let's not take a patient in the ward, which patients in the let's take off septic shock out of the equation completely. we're taking out septic shock out of it because septic shock, you don't think, you just send blood cultures and you may want to send multiple, you may send even 3 sets for that matter to get positivity if it's septic shock and it's coming from other hospitals and things like that. But which patients in the intensive care you would not send a blood culture?
So there is a guideline for this, which came last year out of necessity. Why necessity? Because backpack bottles got shortage by US में. Somehow they were not producing enough, so it became a necessity for them to ration cultures, and they made a guideline for this. So I'll just tell you. So is severe sepsis or septic shock or endocarditis suspected or no? If yes, 2 peripheral cultures, forget it. Again, as I said. If no, then your pretest probability has to be checked. And what are the high pretest probabilities? There are 5 diseases, 6 diseases I mentioned. One is catheter-associated bloodstream infection, discitis or native vertebral osteomyelitis. Second. Third is epidural abscess. Fourth is meningitis. Fifth is non-traumatic native septic arthritis. Sixth is ventriculoatrial shunt infections. Okay, these are a probability of more than 50% of getting a blood culture growth. And intermediate risk is acute pyelonephritis, cholangitis, non-vascular shunt infections, prosthetic vertebral osteomyelitis, severe CAP, and cellulitis with comorbidities and a VAP. So these 8-10 indications, beware, send, not for everything else.
So this means to say, if what you are doing now, you have a patient who's an obvious urinary tract infection. It's an obvious urinary tract infection. Patient is having clear suprapubic tenderness and he's hemodynamically stable. He comes with 1 fever spike and he's old. That's why he comes to the ICU. He's old and he's kind of disoriented. That's why he comes to the intensive care unit. You unfortunately, you already have a source of infection as the urinary tract, and the urinary tract infection may not lead to bacteremia very quickly. It's not common to septic shock. It's a very simple organism infection to treat because it's a UTI. It goes out. It's got it's got a natural source control, isn't it? So in such a cases, this doesn't make sense. Doesn't make any sense for you to send off blood cultures. You're going to get a urine culture that's going to come in very quickly. You don't send blood cultures. Similarly, you have a patient who comes in, who is coming with, say, a respiratory tract infection. Okay, the infection is such that it is not a severe CAP. There is something else. There is a small patch in the lung. Okay, but there is something else. Some other pathology is going on somewhere in the abdomen or things like that. There and which is not related to infection. It is something else. Maybe some intestinal obstruction, but not really transmission, things like that. And the patient is in the ICU. You don't send a bacteria, a blood culture for that. You got the point, huh? You don't send a blood. You wait for that unless the patient got severe community acquired pneumonia, which is defined as mechanical ventilation on a vasopressor and multiple other reasons to believe that this PF ratios are low and nothing like that, which you send a severe. Because what the issue is, you may not get anything. If you don't get anything, then you will be, rather than actually doing a bronchal or something like that, you will be it will just add to costs. It's not something that we should do. You got the point. Huh? So which patients you should not do blood culture is very important. And if you're doing it, ensure that you explain to the nurse. See, we have a lot of attrition among nurses, as Dr. clearly mentioned. It has to be done the right way. The moment it's done the wrong way, everything goes down the drain. The other day I was suspecting a CLAPSI on this patient over here, and the nurses sent one from the arterial line and one from the central line. Oh, what do I do? What do I do with that? There's nothing I can do with that. So what is the issue here? I was suspecting CRBS. I wrote on the paper, sent for CRBS paired cultures. What have you done? You have not explained to the nurse that what you are supposed to do. You send one from here, it's sterile precautions, send one from there, it's sterile precautions, and then we'll have to figure out the differential chapter positivity, label it properly. She sent it from here, and labeled it arterial and central line and sent it down to the microbiology. Now this makes it very difficult. So explanation is very simple. Do the simple things best. If you do the simple things best, then everything else falls in place. That's how it is. Yeah. So thank you, Roshni.
A couple of things I missed out. Now in the culture bottle, there is one more way. Does Candida grow in this, or do you need to send a separate fungal blood culture? You send urine fungal culture, you send everything as fungal culture. So blood carrier you send suspecting Candida. Urine में Candida है. Candida grows very well. Okay, Candida grows very well. However, if you're specifically thinking of a fungal infection, there is another bottle called as Myco F Lytic. Okay, it's a red top. Okay, उसका full form है Myco F Lytic. F is for fungus and myco is for mycobacteria. You get even norovirus mycobacterial growths in blood cultures. I have to send this. This is kept in the. अभी तुम ये bottle भेजोगे. How long is it kept in the lab? Last thing.
72.
5 days.
More than
5 days it's kept.
5 to
The
10 days.
mycoenclytic is kept for 3 to 4 weeks for delayed growth of organisms like fungi and mycobacteria. If a patient has received antibiotics outside, despite if the 5th day growth is negative, you ask for the culture to be kept for extended incubation, which is what I do in the lab. I send them the blood culture details, you keep it for 10 days, keep it for 15 days to increase blood culture yield. So despite sending it in a resin bottle with 20 ml of blood in this thing, you may still get a negative blood culture in a bacteremic patient. Ask them to keep it for extended incubation or prolonged incubation.
And that's what we should do because by definition they'll keep only for 5 days.
I definitely keep for 5 days. 120 hours is their guideline. But you should ask in the lab. You should ask them, see, don't discard this bottle. Then they ask, कितना दिन रखना है? So ask 10 days. Okay. 10 days में negative है, then it is actually negative.
We should be doing this for every or
For suspected sepsis with no other answers.
that's why we will be knowing this only after 3 days that there is no organism. So after 3
They will come to know till day 5. They will keep it till 5. 120 hours होने के बाद ही bottle discard करेंगे till there is no growth. But if day 5 you're still stuck for a diagnosis, the culture is not grown anything, patient is not improving, then you'll ask them to keep it for
At that time we'll call them and tell them, please keep it for an extended duration because we need to figure out what's happening. We don't know what's happening.
They will check with the same bottle. मतलब reculture the
Reculture नहीं,
Same bottle
keep it for
continue
longer
करेंगे.
time.
Okay, अच्छा.
And many times you've gotten the answer at day 8, day 9. कितने सारे vertebral osteomyelitis हो गए pre-treated antibiotics have kept cultures for 15 days. I would do Pseudomonas on day 12 and all. You have many examples.
So this patient last time he has flat GMB now. Like previous it was no growth only.
On the blood.
Yeah, but we have some repeat culture.
Yeah, because we were not getting an answer.
Answers.
So that's why we told them to repeat the
But he
culture.
is a urosepsis also, no? So UTI
Yeah,
right
yes,
now.
है.
So this is less likely a gram negative and more likely a gram positive. The leg.
Like the UTI is coming causing gram negative. Mostly. Okay.
Why not to send a arterial culture, like arterial blood
We do send.
We can send.
No.
So this when you say CRPSI, no? When you say CRPSI, it can be central, it can be arterial, like it can be catheter related, right? So if you are thinking that the artery is the source of the infection, then I would send from here in the periphery. I can send from arterial puncture, provided I am suspecting that is the source of infection. Not that if I have to suspect like that. You understand? So if I am putting a freshly placed arterial line, I can send that as peripheral culture. A freshly placed arterial line, I'll send as peripheral culture. One from there, I'll send as peripheral culture. Okay. Any other questions?
Ideally, we have to send 2 sets for any septic shock patient. If we are getting the
Then set
proper
3, nothing like it.
हाँ.
Methodologically, there are
Expensive
problems.
is
So
another. Yes.
2 sets is ideal. Avoid sending 1 set when you're suspecting sepsis.
Any form. If you are getting both the Q bottle, then Q bottle,
from Q
or one as a
Freshly
peripheral
put line,
from
then from
Okay.
fresh line.
So ideally 2 sets have to go. You
yes.
can't set 1 set. 1 set will actually reduce your sensitivity.
Sensitivity.
So you really can't do that. You have to always set 2 sets. Unlikely. So one question I had in my mind, Siddharth, was this is my question, okay? So when you have pediatric sepsis, we give 3 ml of blood. Isn't it? We give 3 ml. So why don't we use 3 ml for adults also? The question is, if anyways the pediatric sepsis is getting picked up with 3 ml of blood, so why don't we send 3 ml for adults also?
Their bottle is different and
So why
their
don't we
sensitivity is also.
So why don't we use that bottle? The question is, why don't we use that bottle, say 3 ml? Because otherwise what is going to happen? We are sending 40 ml. You know, we are essentially by the day 4, day 5 patient's hemoglobin is dropped by 2 grams. Okay. Now, if I were to actually send a pediatric bottle peer culture and send 3 ml, I will definitely reduce the amount of blood transfusions. Na?
So this question I had put to some senior microbiologists. So there is no standardization. First, for adult samples in a pediatric bottle. Pediatric blood culture positivity rates are also quite low because of low yield. They have designed the bottle to somehow enhance the experience on a 6 ml sample. However, it's not at par with an adult sample pickup. It's not at par. That is the first thing. Second thing is we do use pediatric bottle for a different reason. When I do my CSF cultures. When it gets a CSF you can't get a lot of samples and more often than not your CSF will be negative culture wise. So if you can get 2 or 3 ml of CSF extra, put it in a pediatric bottle, in a pink bottle. There's a pink bottle of a pediatric blood culture. The pink bottle में डाल के अगर आप भी भेजोगे ना, most often than not you will get a strep pneumococcal, strep pneumonia. This is how you enhance a CSF culture. Also for a skin soft tissue infection, many times at least because they had a different orthopedic ID unit at individuals to do only infected cases, they used to inoculate pus in these bottles and send.
Plus even ascitic fluid.
As pus हुआ, ascitic we've sent so many. So we use these bottles for everything other than urine. And once I even tried urine, but मुझे labs में पढ़ा मुझे to get a culture group. But for everything other than if you have a liquid sample, you can inoculate it to this bottle, send it in this bottle, whatever you can. And very ideal for pus samples, very ideal because pus will usually not grow in a pre-treated state. But these bottles we've kept it in the lab for 15 days. कितना भी pre-treat करो अगर pus है तो growth आता ही.
But at the end of the day, this is not a substitute for PCR. PCR is not a substitute for blood. It's not a PCR. Even if you are sending PCR, you still have to do blood cultures. You're understanding? So you will say, I'll send a BCID panel. So BCID panel ऐसा नहीं है कि तुम blood से निकालो. But there has to be a colony committee. Then the BCID will go out. You got the point. You cannot negate the blood cultures. In fact, if you get a BCID positive, you don't get sensitivity patterns, right? You only will get some resistance patterns. That is why you need to still send your blood culture. It's very, very essential, and that's why this entire topic, the blood culture, has to be sent well. It's very, very important. Okay?
An entire BCID study that I've done for 3 years. I'll present it sometime. Lot of interesting findings.
So we want you to do this every Thursday for some 15-20 minutes with us. This, okay. So next time we will do something else now. We'll stop for now. Thank you.